The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.
Welcome to Spot the Bleed, an American Heart Association ICH Guideline Refresher Series, the podcast dedicated to providing comprehensive insight in hemorrhagic stroke care. I'm your host, Sue Abel, Program Consultant at the American Heart Association. We're excited to bring you content that addresses guideline-directed care across the continuum, from patient diagnosis, treatment, and all the way through secondary prevention. In each episode, you will hear from our clinical experts as they break down the ICH guidelines into tangible offerings. Thank you for joining us today as we aim to equip you with refreshed knowledge to enhance ICH care and drive positive outcomes. Let's get started.
Welcome to AHA Podcast. My name is Dr. Minsun Kim, and today we're diving into an incredibly important topic, recovery after an intracranial hemorrhage, or ICH. After the acute crisis has passed, what comes next and what does recovery look like? And how can we best support our patients and caregivers through what is often a long and winding road? Joining me today is Dr. Simona Nedelcu, a vascular neurologist who has worked with hundreds of post-ICH survivors. Welcome, Simona.
Thanks, Minsun. I'm really excited to talk about this. Post-ICH care is often underrepresented in discussions about stroke, but it is absolutely vital for long-term outcomes.
Okay, let's start from the beginning. What does the latest AHA guideline say about where and how recovery should take place?
Recovery ideally starts in a specialized stroke unit staffed by a multidisciplinary team that consists of neurologists, nurses, physiatrists, physical and occupational therapists, speech-language pathologists, psychologists, and social workers. This team-based approach has been proven to reduce mortality and disability even in severe ICH cases.
So extend it beyond therapy, emphasizing early multidisciplinary coordination from specialized services.
Exactly. Every team member plays a critical role, and an important early focus is discharge planning, even within the first few days of hospitalization.
Then let's talk about discharge. What does early supported discharge, or ESD, mean in practice?
For patients with mild to moderate ICH, typically a modified ranking scale score of 3 or less, early supported discharge means patients can leave the hospital sooner but still receive high-intensity rehabilitation at home or in a community setting. The key is continuity of care and maintaining rehab intensity.
It sounds like this model empowers patients in their own space, and it's been shown to work internationally, including Sweden, Canada, and Thailand.
Exactly. Patients feel more in control, and outcomes like mood, independence, and quality of life often improve. But of course, follow-up is critical.
At our hospital at Brigham and Women's, we have a clear post-discharge pathway, stroke neurology clinic, neuro recovery clinic, PM&R, and patient needs a real medical home for their post-stroke journey.
Yes, continuity of care is key, both for medical follow-up and for helping patients transition from hospital-based to community-based recovery.
Now let's talk about timing. When should rehabilitation ideally begin?
Within 24 to 48 hours post-ICH, assuming the patient is medically stable. This might include light stretching, sitting up, or grooming tasks, but not high-intensity workouts.
So earlier rehabilitation isn't always better?
Correct. The AVERT trial showed that aggressive mobilization within 24 hours can actually lead to worse outcomes, including increased early mortality. So we want early but gentle rehab, restoring basic functions without overloading the system too soon.
So early but not too early, or not too intense.
Precisely. It's a balance, starting gentle tasks like stretching and basic movements soon, but avoiding overly aggressive activity right away.
Now let's get into post-stroke complications. What do patients often experience after intracranial hemorrhage?
There's a broad spectrum of complications. Let's break it down into physical, cognitive, and emotional categories. Regarding physical complications, we can think about hemiparesis or weakness, which is very common and affects about 60% of patients acutely. Another physical complication is spasticity, which affects about 40% and can lead to joint contractures if not managed well. Another complication can be dysphagia, which is swallowing difficulty and can affect up to 50 to 70% of our patients. And this in particular raises the risk of aspiration pneumonia. And lastly, one of the most important physical complications are falls and mobility impairments, which are major risks in the recovery of these patients.
Wow, there are a lot of physical complications that can occur after stroke. And what about cognitive and emotional symptoms?
The cognitive or emotional complications is where things get really complex. There are a number of important post-stroke complications, such as post-stroke depression, which can affect up to 20 to 25% of ICH survivors within the first year. There's also cognitive impairment, which is present in up to 50% of patients, even the ones who have mild strokes. There's emotional incontinence, such as sudden crying or laughing, which affects 10 to 20% of patients. And there's also, importantly, post-stroke fatigue, which is profoundly disabling, and it is reported in up to 60% of the survivors.
We recently saw a really interesting case. A 35-year-old man who had a heart transplant, and not long after that, he developed a large brain bleed in the left basal ganglia. His wife started noticing some changes in his behaviors. For example, the patient experienced sudden outbursts of angers, and he would get this frequent uncontrollable crying. And he would normally be a very empathetic person, but he would exhibit generally a lack of empathy. This is actually a classic examples of what is known as post-stroke emotional incontinence, or PSCI. The basal ganglia is a deep regions of the brain that is rich in serotonin pathway, and this serotonin, as you know, plays an important role in how we regulate emotions. So the damage to this area of the brain can frequently lead to emotional dysregulation, as seen in this case. We started him on fluoxetine, which is a type of SSRI medication or selective serotonin reuptake inhibitor that works by increasing serotonin level in our brain. As a result, our patient showed a drastic improvement in his symptoms. I thought that it was a great reminder of how closely our brain anatomy and chemistry are tied to our emotional behaviors, and these symptoms are indeed very common after stroke.
Interesting. There used to be some concern that SSRIs might increase the risk of bleeding, especially in patients with ICH. That was based on early observational studies suggesting a potential link between SSRIs and platelet dysfunction. But more recent research, including a large cohort study published in JAMA Neurology in 2021, found there was no significant increase in blood expansion or mortality among ICH patients treated with SSRIs. In fact, some studies even suggest that SSRIs may support neurological recovery. So the current thinking is that SSRIs can be used safely in patients with ICH as long as there's thoughtful clinical judgment.
Exactly. And the idea of using SSRIs for recovery brings to mind the FLAME trial. The FLAME trial was a randomized controlled trial that looked at fluoxetine specifically to see if it could enhance patients' motor recovery after stroke. But later trials like FOCUS and AFFINITY didn't show the same benefit as the FLAME trial. And while there is some promise, there is still ongoing debate about whether fluoxetine influences positively on patients' motor recovery. And that's why treatment really need to be individualized, especially in ICH patients. Let's pause and talk about post-stroke fatigue, or PSF. PSF affects up to 40 to 70% of patients, including those with ICH, and it is not just feeling tired. It is a chronic, often disabling exhaustion that does not improve with rest. So many of our patients experience PSF.
Exactly. One of the most common and most under-recognized complication is post-stroke fatigue. PSF can really derail recovery. It impacts engagement in therapy, social interaction, even in basic activities of daily living.
So how do we treat it? Or are there any evidence-based strategies?
There are a few, but unfortunately, high-quality evidence is still limited. This is what we know so far. Exercise and graded activity. According to a 2021 Cochrane review, it seems that the research supports graded physical activity as a first-line strategy. Low-impact aerobic exercise like walking or cycling can significantly reduce fatigue over time. Even short, regular activity has been shown benefit in trials. Furthermore, sleep optimization. More specifically, sleep apnea is very common after ICH, so improving sleep hygiene and screen for insomnia or hypersomnia is very important in these patients. There are psychological approaches such as cognitive behavioral therapy or CBT, which has shown promise, particularly when fatigue coexists with depression or anxiety. Importantly, CBT can help reframe unhelpful thought patterns and support pacing strategies. And finally, there are pharmacological options. There is limited but emerging evidence that modafinil is important in post-stroke fatigue, according to a few small randomized controlled trials, which suggest that it may help in select patients. SSRIs, when treating comorbid depression, can also sometimes indirectly reduce fatigue.
So we use a stepwise approach that starts with lifestyle and therapy-based interventions, optimize sleep, and consider medications carefully.
Correct, and always personalize. Some patients may improve just by regulating their sleep and routines, while others may need more structured interventions. Let's talk about what recovery looks like over time. ICH recovery is often nonlinear. Initial gains may be rapid in the first 1 to 3 months, but improvements can continue for a year or more after the injury, especially in cognitive and emotional domains. Recovery can plateau, then improve again with targeted therapy or medication adjustments. We've seen patients return to work, sports, or parenting, even after severe ICH.
Recovery after ICH is a marathon, not a sprint. We need to give patients and families realistic expectations and hope.
Exactly. Lifestyle modification is another pillar of recovery. The most important intervention is strict blood pressure control, ideally less than 130 systolic over 80 diastolic.
That's right. And beyond that, lifestyle modifications such as smoking cessation, regular exercise, DASH or Mediterranean style diets, limiting alcohol, and treating underlying sleep apneas are also equally important.
Exactly. And don't forget the caregivers. They're the hidden engine of recovery. The AHA guidelines stress training and supporting caregivers, which improves both patient and caregiver outcomes.
Great. That's a really great point. What are the unknowns? And where do we still need some more data?
There remain several important questions and knowledge gaps, such as what's the best approach to returning to work or driving? Then, how do we manage sexual dysfunction post ICH? Another important question is can neurostimulants improve attention or fatigue? Then, is telerehab truly equivalent to in person rehab? And then, what about culturally tailored rehab models for the diverse populations?
All excellent questions and ideas for future research and future podcast episodes as well. Simona, thank you so much for joining today Today's conversation really highlighted that ICH rehabilitation is not one size fits all, but it is dynamic, multidisciplinary, and deeply personal.
Absolutely. The more individualized and compassionate our care, the better chance our patients have for meaningful recovery.
And to our listeners, thank you for joining us today. Remember that rehabilitation isn't just recovery, it is about reclaiming life. Stay tuned for more episodes from the AHA podcast.
Thanks so much for listening today. If you would like to find out more about the AHA Hemorrhagic Stroke Initiative, please visit www.heart.org/hemorrhagic stroke. See you next time.
The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.